Science in the Wittich Research Lab at the School of Optometry at Université de Montreal. His postdoc work aims to explore ways in which we can prepare the Canadian healthcare system to meet the needs of older adults who have dual sensory impairment. Atul completed his PhD in rehab sciences from the School of Rehabilitation Therapy at Queen's, and his doctoral research focused on identifying ways to enhance the participation of persons with deafness and blindness or dual sensory impairment in society. His work also focused on understanding the use of assistive technology for persons with DSI. He's a trained occupational therapist as well as a rehabilitation social worker. My background, social work, so I'm delighted to have him on board, with experience of over 7 years in the field of disability rehabilitation. I was fortunate to meet Atul when we were attending the virtual sessions of the Canadian Association on Gerontology, and we had similar areas. I'm also interested as a newbie in dual sensory impairment. Atul has already written or co-written over 50 publications, including a scoping review of vision rehabilitative services in Canada, that's documenting important gaps in vision rehabilitation services and research evidence across provincial jurisdictions, which I think will be of particular interest to many of our viewers coming from the service-oriented organizations. We're looking forward to his talk today, which is entitled Healthcare for Older Adults with Concurrent Hearing and Vision Loss, an examination of the impact of COVID-19 on their access to healthcare and health-related information in Canada. So very current, and we're looking forward to hearing from you. Thanks so much for being here, Atul. The floor is yours.
Yeah, thank you so much, Dr. Phil Thompson, for having me here today. Hello, everyone. My name is Atul Jaiswal, and I'm a FRQS Postdoctoral Fellow in Vision Science at School of Optometry, University of Montreal. The work that I'm presenting today is coming from my CIHR Health System Impact Postdoctoral Fellowship that I just completed in December 2021. And my fellowship research was jointly funded by CIHR, FRQS, and INLB. Now I've received a third-year award from FRQS to advance my efforts of knowledge translation and design training modules for healthcare professionals on sensory loss. So in my current research, I'm trying to generate evidence on the continuum of healthcare for older adults with combined hearing and vision loss in Canada during COVID-19 pandemic. So this presentation is all about trying to understand what are some of the access to health barriers to access to healthcare and health-related information for older adults with dual sensory loss in Canada during this pandemic. So I acknowledge that I live, work, and raise my family on traditional homeland of Anishinaabe, Haudenosaunee, and the Huron-Wendat. I'm in Kingston right now. I would like to acknowledge my funders and research partners' support for this project, and I would also like to thank Institute for Life Course and Aging, especially Dr. Fuller and Susan for this opportunity to deliver this talk. Hearing loss, I think before I go further, I think I wanted to touch base on like what is hearing loss, what is vision loss, and what is dual sensory loss, because that sets the foundation for this whole talk. So hearing loss refers to loss of hearing and greater than 26 decibel in better hearing ear. Related hearing loss, which is also called presbyocusis, is a very more common in older adult population. And vision loss is defined as visual acuity worse than 0.3 log MR or worse than 20/40, where mild vision loss or low vision is acuity worse than 20/40, and blindness is acuity worse than 20/200. Visual acuity is the ability to see details clearly regardless of the distance of the object. A combination of hearing and vision loss is referred as dual sensory loss, and it can range from low vision and hard of hearing in the same individual to total deafness and total blindness. So I think I would like to pose this question to all of you, that does sensory impairment really matter? And I let you think over it, because I think that's what is the whole essence of this talk. Because if we are doing aging research, if we are working with older adults to improve their quality of life and healthcare, do we think that sensory impairment matters? Let's see what World Report on Hearing and Vision from World Health Organization talks about it. So World Health Organization first report came out recently last year, that's called as World Report on Hearing, that estimates that approximately 1.5 billion people currently experience some form of hearing loss, which then this number would further grow to 2.5 billion by 2015, which that means approximately 1 in 4 individual will be having hearing some form of hearing loss by 2050. The World Report on Vision came in 2019, and that estimates that globally we have around 2.2 billion people who have vision impairment, and of these, approximately 1 billion people have vision impairment that could have been prevented by providing better access to care. Some global facts. So 2015 report on global burden of disease estimated that hearing and vision impairment respectively ranked second and third of all impairments, contributing to the number of years lived with a disability. So just to sort of highlight the gravity of the issue that we are referring to. And so globally, as I talked about, so as per World Health Report, 1.5 billion have hearing impairment, 2.2 billion have vision impairment, and approximately 150 million people have combination of both. This is called dual sensory loss here. So now let me take you to the dual sensory loss space and why I'm interested in this space, why I'm into this field of dual sensory loss research. I believe this is a more complex population to work with and has its own distinct set of challenges. So deaf blindness or dual sensory loss is a varying combination of hearing and vision impairment in the same individual that affects their communication, access to information, mobility, and functioning. So I'll use this quote by Helen Keller that rightly describes their situation. Blindness cuts us off from things, but deafness cuts us off from people, and that highlights that people who are only have vision or only have hearing impairment, they could still compensate using the other intact sense. But for those who have concurrent hearing and vision loss or deaf blindness or dual sensory loss, it is not possible to compensate in the best possible way. So they have more challenges to face. So as per the current estimates, that's I guess up to 2% of the, as per this current report that you see on the screen, it's estimated that to 2% of the world population have this impairment, which means approximately 150 million people in the world. A study by Swanner and colleagues highlighted that 14.5 million people in the North America itself will have this condition by 2036. And approximately 1.1 million people in the Canada itself might have this condition as per this CLSA report that came out in 2016 by my supervisor and the colleagues at CCNA. Now here I highlight some of the unique challenges that these individuals face. So because of dual sensory loss, they have difficulty in engagement with the environment. Mobility is an issue. Establishing and maintaining interpersonal relationships is an issue. Communication with the world is a major concern, and that overall affects their functioning and finally restrict their participation in society. And through that, this particular dual sensory loss is seen as or considered as one of the most isolating disabilities to work with. So again, pose a small question here: that do you think older adults with sensory loss are equitably represented in the COVID-19 pandemic research? And that was the whole question that basically helped me to drive this research that I'm doing right now and that I'm going to present to you all of you today. So older adults with dual sensory loss are often sidelined in vision and hearing research, and evidence suggests that they are at high risk of cognitive impairment, functional decline, social isolation, falls, depression, and mortality. They often are high users of healthcare services due to comorbid conditions like stroke, hypertension, cardiac disorder, diseases, and depression, mental health, sort of anxiety. And because of that, they are often high-end users. But often when healthcare professionals are working with them, either they only see the condition, the comorbid condition, that could be any hypertension, stroke, or other neurological disorders, or they only focus on the sense impairment piece. So I think that there's a need for seeing the holistic, so seeing it from a comprehensive way. Because communication is severely affected between older adults with dual sensory loss and their care providers, they often have poor access to healthcare and face more structural and psychological barriers in accessing healthcare services than their non-disabled, non-dual sensory peers. However, there's a lack of sufficient scientific evidence to inform clinical practice for equitable access to healthcare for older adults with dual sensory loss during this current pandemic. So therefore, my study aimed to explore the barriers to access to healthcare services and health-related information for older adults with dual sensory loss in Canada during COVID-19 pandemic. So I'll talk about two research studies here. Study 1 is qualitative study with older adults with dual sensory loss and their care providers. So in total, I had 32 older adults that I interviewed and 32 caregivers or support providers who sort of we conduct who were also involved in focus group discussions to collect data from them to understand their perspective. And the study 2 is an online survey with healthcare professionals with 228 healthcare professionals and followed by 24 sort of in-depth interviews with a few of them who were ready to elaborate more on their survey response. So now I'll start with qualitative study findings. So we conducted semi-structured qualitative interviews with 32 community dwelling older adults with dual sensory loss in Quebec and Ontario last summer. And diverse remote communication modes were used and accessible formats were used to obtain consent and interview older adults. Like imagine that you have to interview someone who is having difficulty in seeing and difficulty in hearing. So how hard it would be for them to respond to my question, and also for me to understand what they're trying to say to me, right? Because they might not be able to. So there's a problem of being understood and understanding what other person is trying to say. So communication is inherently a big challenge in this group, and that's why diverse remote communication mode and accessible formats were used. I'm writing papers on all of this, so hopefully in end of this year we'll have all those papers out. Online focus group discussions were conducted with 32 caregivers or support providers. When I use the words caregivers or support providers, I mean people who help them to access healthcare. So if there's an in-person sort of care, then people who are helping them to go and see or go and have a healthcare consultation with their doctors in a clinical setting, or there could be a telehealth appointment. So the person who's sitting with them in their house, helping them to use telephone or helping them to use technology like Zoom or any sort of computer-based platforms. So an interview, the duties were audio recorded and transcribed verbatim. Data were analyzed using NVivo software, and a thematic analysis approach was used to analyze the data. So the key findings from this particular study was access to healthcare, like major informal supports that were available to help access healthcare for these individuals were spouse, siblings, children, daughter-in-law, friends, and guide dogs. So these were the informal support that were there that helped them to access healthcare during this time of last 1.5 years. And major formal supports came from social workers, rehabilitation agency staffs, and interveners. Interveners played a big role here, and they helped them because they are paid professionals who are trained in this field of deaf blindness communication. So they were there to help these individuals access healthcare. COVID-related health information is accessible through the help of family caregivers, or even I'll say interveners, but pretty much all their like all of these individuals are not readily available these days because we know of the different restrictions that are out there. Due to COVID-19, no voluntary support which were initially available before COVID-19 is no more available for these individuals. So that added more caregiver burden for caregivers and support providers. Care delivery via telehealth services using phone and technology was found to be challenging for all these participants. And so regardless whether it was older adults responding to our questions, or it was the care providers or like interveners and family caregivers, they all said that they had a hard time using telehealth approaches. And hospital staff is not trained to work with older adults with DSL. That's what most of the individuals highlighted in our sort of qualitative study. So the key findings here are, I'm going to talk about all of them one by one. This is a synthesis that I'm presenting to all of you today. I'll first start with the lack of training, time, and comfort. So in this particular thing, most of our participants, like be it older adults with dual sensory loss or the care providers, like family or informal and formal care providers, they found that there was a lack of training among healthcare professionals about how to provide care to, or how to meet accessibility needs of these individuals and how to communicate with them. Because if healthcare communication is affected, it's going to surely affect the health outcomes that person is trying to accomplish. The lack of time and comfort for the healthcare professionals to go beyond their traditional boundaries or scope of practice and do more than their work. So because often if you're working with older adults with concurrent hearing and vision loss, you might have to interact with other healthcare professionals who like maybe with also sensory rehab professionals like vision care providers and hearing care providers to understand what all best could be done in this case. Uh, Environmental inaccessibility was a major concern because older adults with dual sensory loss, they found they had difficulty following 2-meter distance requirement, which was often a classical case in our all healthcare setting where you have colored lines painted on the floor. So these individuals had hard time following the distance, the 2-meter distance that was required. The physical layout of the clinical setting is also often not accessible to these individuals, and often hospital staff was not trained. So trained how to navigate or how to help them navigate the clinical setting that where these older adults were trying to access healthcare. Telehealth challenges. So often people who were trying to use healthcare, access healthcare using telehealth approaches, like be it using phone or be it using a computer-based approach. So in both the cases, sometimes because of vision difficulties, they're not able to follow, or they're not able to follow the phone numbers on their phone, or also it's hard for them to understand whether the person is trying to say if it is a computer-based approach. So a lot of this was somehow managed through the care of like support providers that were there, either family members or interveners who were there, but this support got further restricted during this COVID-19 because of all the restrictions that we have in place. And health information often that was provided to these individuals were often in inaccessible format that was not good for them to access. So these all, and then finally the client provider interaction concern. So the healthcare professional, if they are not aware that this particular individual or this particular patient have concurrent hearing and vision loss, they might not know that they need to give more time, more pause, and speak slowly so that the other person can understand. So often the healthcare communication was a bit affected, and it was not good for either parties. Yeah. So here are some of the participant codes that I'm highlighting here. So you can see hospital staff don't know how to recognize, how to adapt to a deafblind person. It is necessary to inform them. And the other participant highlighted that doctor is talking to 2 or 3 people. So if there's a speech in noise, or there's a lot of background noise in the clinical setting, these people have really hard time following what is being said to them. And when now the third participant is trying to say that with the glass barriers or plexiglass, whatever is up, I hardly hear anything that the healthcare professionals are saying to them. So some of the codes that came that more focused, they were more focused on telehealth. I like this a lot less. By phone, I think it's not the right way to care for people. I can't hear on regular telephone. So because of hearing loss, there were some challenges of obviously trying to understand what the other person is trying to say. And with the vision impairment, because you're not able to see the facial expression, body, the lip reading is also gone because of the use of mask. All this has further complicated the scenario for them to rely on other senses and understand the healthcare communication that is happening between them and their care providers. Just one sec, I apologize. There's a little bit of technological issue with my mouse. So, okay. Yeah, sorry for that. So now I'm talking about healthcare, the key findings from the online survey that were conducted and the subsequent in-depth interview with these healthcare providers. So online survey was conducted with 228 healthcare professionals working in various settings in Canada, various clinical settings in Canada, like long-term care, palliative care, community care, primary care. And then followed by that, we had in-depth interviews with 24 of those survey respondents to elaborate more on their responses. Content analysis was used to analyze the qualitative data, and whereas descriptive statistics were used for the quantitative data that came from the survey. Majority of participants were females, almost 76% of them, and they range from like 26 to all the way to 60 plus. Majority of participants were working in Quebec, followed by Ontario, Alberta, and they had various jobs, but majority of data came from pharmacists. Almost 28% data came from pharmacists, followed by nurse, and then therapist, and then audiologist, optometrist, and ophthalmologist and psychologist. And almost half the participants had more than 10 years of experience in their job roles. Now I'm again presenting the key synthesis here. The challenges experienced by, like in this, from the survey data, as well as the interview sort of that we conducted with them. The key challenges that were highlighted where the identification of dual sensory loss was a major concern for them. So it was very hard for them, for the healthcare professionals, to understand that this particular person has a combined hearing and vision loss. So because unless until they know that thing, then only they can start thinking, oh, what I can do. So that was a big concern. So it took a lot of time for them to understand that this particular person is having dual sensory loss. And often that was happening in a scenarios like, for instance, like whenever a healthcare person is trying to explain the whole thing to them, and then they're asking the person to repeat it back, then they get the response from this older patient that this particular person has not understood anything. So because of the response that came in return, that gave them a red flag that maybe this person has more than what I can see on the file. So then they start to tease out that maybe it's a combination of hearing and vision loss, both the things. If people are using hearing aid, that gives them a clear-cut clue that maybe they might have a hearing loss. If they're using glasses, if they're asked for their magnifier or something else, then they realize, okay, they might have vision loss as well. So through these different approaches, somehow they are managing, but identification of dual sensory loss was one of the biggest concerns that they pinpointed to in the survey, as well as the qualitative responses that they gave. Communication, health-related communication, again became a very sort of key area of challenge. And we totally understand that was a challenge before COVID-19, and that has become further exacerbated during this time. And I will give you a good example how it got further exacerbated. Like the use of masks, because of the use of mask, the lip reading is gone. And because of the lip reading is gone, and the voices also get muffled between the PPE and other sort of different equipment that people might have to use these days, especially the healthcare professionals. So if the sound is not coming out clearly to the older adult, older patient, and be it in person or be it on tele approach, both the ways, mask and use of PPE restricted the communication and created more challenge for these individuals to have a effective health-related communication between them and their patient. Consent was a big concern for them, because often they will explain everything to this patient, and then this patient has hardly understood anything. And so people often went ahead with their approach because they assumed that, yes, this person has sort of given me a sort of consent to be here and to treat. So that's why I'm going ahead. But pretty much consent was a big concern always for them. Then it was always also a concern because they have to rely on other like family members or care or like family members or interveners to facilitate the communication between them and the patient. So, and that would also have some sort of privacy issues, because maybe this particular older adult might not like all the information to be passed to this person, but the situation is like that. The healthcare provider is also trying to communicate with this person who has no hearing and vision impairment, as compared to talking to older patient directly who has hearing and vision impairment. So there are a lot of indirect communication happening. And often, though a healthcare provider might identify that this particular person has dual sensory loss or concurrent hearing and vision loss, but how they're not trained how to communicate with this person. So that was another major concern that we saw in the data with respect to health-related communication. And also, they all reported that time was a big concern, because it was very clear that individuals who have sensory loss or dual sensory loss, they need more time to understand what is being said to them. So, but that much time often is not available with all their healthcare providers, who have a fixed sort of time slot for all the patients that they have to see during their rooster. So, and then finally, restricted healthcare accompaniment. Often, like if it is a setting which is long-term care setting or other, only essential care partners are allowed or caregivers are allowed. So in that situation, often people were not, and there was a fear of infection. So that also led to restricted healthcare accompaniment policies, and that led to So if the older adult is not able to have someone with them while they are trying to access care, it was a bit of a challenge for everyone, because this particular older adult might not have a clear idea where to go and how to follow the steps so that they can go and see the particular doctor or person in a respective room. That was a bit challenge. And if the healthcare accompaniment person who was there, but the person was not allowed to be with them, it was also a challenge for them, because they might, like, if they're interveners that were hired to be there, but if they're not allowed to go in with their older patient, then it was a waste of their time as well as energy. And finally, the technological challenges that I already elaborated, but healthcare professionals also elaborated on those, that they could see that the older patients had had a bit of a struggle to understand how to use technology, how to use phone. And often I'll give you a very good example here, that when right now, when you have to book a healthcare appointment, you have to follow a series of steps when you're calling someone and trying to, let's just take an example of blood work. If you have to get your blood work appointment set up, you need to call and then set up, follow a series of steps that will be coming from the IVR. And if you're not able to follow those steps, that okay, now dial 0, dial 2, dial 5, it's a bit of a complicated process for these older adults who have concurrent hearing and vision loss. And finally, the limited resources and staff. That again was a major theme that came out of the data, that and I think we all are aware of this. But even with respect to keep providing care to older adults with dual sensory loss, it was a bit of a challenge, because if the staff is already overburdened, providing extra time, providing extra support, providing extra having more flexibility in the system was a bit of a challenge for everyone. So now I'm presenting what are some of the current strategies that people are using, regardless whether they have training in the field of dual sensory impairment or dual sensory loss or not. So what is with respect to identification of DSI, and I'm highlighting because I highlighted in the previous slide what are some of the challenges. I think it's important to highlight what people are doing right now to mitigate that, to overcome that challenge. So often people are relying on non-verbal cues to communicate, and through that non-verbal cues, they're somehow trying to figure out, okay, maybe this particular person have hearing as well as vision loss. So that is the identification of persons with the the identification of dual sense impairment is happening through this, as well as building interpersonal relationship with the client. Gradually they are trying to build interpersonal relationship, and through that interpersonal relationship they are trying to figure out, okay, how do you, so do we have difficulty in hearing, do we have difficulty in vision? Because often, because of the stigma that is associated with using hearing aid, stigma that is associated with the disability itself, often people do not see, older adults might not identify themselves that they have hearing loss and vision loss. That was another major concern, but gradually with the building rapport, it works out fine, and then people tell yes that they have difficulty in seeing as well as hearing, and then they often go about and telling that what works for them with respect to communication. So, and then finally, or if the system already has some sort of screening questionnaire in place, that could help to sort of identify dual sensory impairment or dual sensory loss. With respect to communication challenges, people are relying a lot on I'll say extra sort of support or informal care providers like interveners and family caregivers to become sort of the facilitator between of communication between the care provider and the older adult with dual sensory loss. Interprofessional collaboration here. Suppose there's a PSW and then there's a nurse. So if this particular PSW is working in a long-term care, and then they are finding it really hard to follow what this older adult with dual sensory loss is saying to them, then they often go back to their nurse or other team members to understand how should I go about communicating with them. And then people who are there in the system, because they have seen or they might have worked with older adults with dual sensory loss in their previous work experience, because most of the people who responded on this survey data, they had almost half of them had more than 10 years of work experience. So if people have seen, they have some of their own strategies or ideas how to get the communication across. So through this interprofessional collaboration and sharing the information, it is working right now. Adapted PPE, people have come up with their own mask that they have transparent sheet. So that's what people are using. But even I will say that though adapted PPE or adapted mask with a transparent sheet seems to be a possible solution, but it is not the best solution as of now, reported by some of my participants, because they said that it often gets fogged up, just like the way our glasses get fogged up sometimes because you're using mask. So with the transparent sheet, often that gets fogged up. So I believe that could be a whole new study to explore whether transparent mask could be beneficial in this case of older adults with dual sensory loss. Devices and resources, like people are using iPad, people are using Pocket Talker, all these sort of different devices are out there. It all comes down to the fact that how much aware we are with respect to these devices, like how these devices could be helpful. And finally, using accessible formats. Like a simple, very simple example would be to sort of, if the person have a difficulty in seeing, maybe if you write in big large font, hopefully that should help. Or if you ask the person straight upfront that how you would like me to give this information to you so that you can read it, and they will tell you that, okay, I use magnifier, I use this, or if you print this information in a simple Word file, maybe that might work. So rather than sending everything in PDF and password protected things, I think password protected is still okay, but be sending the information or health sort of information, if it is being sent through email in accessible formats of Word file, that could be a big help as compared to sending it in PDF, which they have really hard time sort of following on the screen readers if they're using that. So the helpful strategies that I'm presenting, what are some of the ideas that people have suggested to us based on the data that we collected. So I'll again start by the first thing, which is in preferred mode of communication. I think asking upfront what is the preferred mode of communication for your older patient with dual sensory loss. If you ask them that, because they are living with that disability and they know how they are sort of managing their day-to-day basis access to information, they will tell you, they will be the best person to tell. Otherwise, if they are not able to tell, at least the family members know what is the preferred mode of communication while communicating with this particular patient. So they can tell you. And once you, as a healthcare professional, you are aware of that preferred mode of communication, then the healthcare communications challenges would be taken care of. Environmental accessibility, this is a very simple, very basic, very cost-effective approach. Though word sounds very big, but it's very simple. It's all about eliminating glare, having adequate lighting in the room, eliminating excessive noise. If there's a background noise, eliminating that, minimizing clutter. If the whole clinical setting is organized in a way that is a bit of a clutter, there are a lot of seats here and there, maybe organizing the environment in a way that it is more simple for older adults to follow, older adults with sensory loss to follow, that will help a lot. So, and then also ensuring that the online system, whatever we have for booking, right, or if it is through telephone for healthcare appointment setting up. So whether that is accessible to these individuals, and if not, then how you can make that accessible, and even sort of seeing that whatever print material you are providing, whether it's accessible to your client with DSI. Finally, the reliable accompaniment support. If the family member or a paid caregiver like interveners are allowed in the system, it will help the communication. So though I say that yes, like but sort of increasing bit of burden on them is not a good idea, but I think having them and having someone who is consistent with these individuals, like they know in and out of these individuals, so having them and having them in the clinical setting or the healthcare appointment would be a really big benefit, because they can tell you how and what is happening in their day-to-day life, and that could give you a lot, like that could give a lot of good clue to the healthcare professionals how to go about providing best care to these individuals. Cross-disciplinary care approach in this, what I mean is that hearing and vision care providers are working with aging care providers, and then we all are coming together to provide sort of best care, if it is possible, under the same roof. Use and maintenance of it, like hearing aids and vision aids, all these are good things, pocket talker, magnifiers, but ultimately hearing, like all these things have to be used by older adults. If they're not using it, if it is just being abandoned for no reason, or maybe for a simple reason of that the person is finding it hard to change the battery of a hearing aid, or the person has a very difficult hand function or manual dexterity is compromised because of age-related changes, so then they might find it difficult. And on top of that, if they have low vision, they might really find it hard to follow the instruction to change the battery or clean the hearing aid. So these are some of the options. So focusing on how to use and how to help older adults use and maintain the different aids that are out there, that could also help in providing best care. And then finally, training on dual sensory impairment or dual sensory loss specific care, like focusing on how to improve accessibility, how to have effective communication with these older adults. I think that training aspect is important for older adults who have this condition, as well as for their care providers or family members, so that they understand what these older adults are going through. And then finally, the healthcare professionals, because if these three sort of stakeholders are aware of dual sense impairment and its implications, and how and what can be done, I think it will improve the care scenario. These are some of the accessible formats just to sort of show it to you here. So Braille, large print, closed captioning, described audio, visual information, information written in plain language, accessible electronic document, so I think PDF is not a good way to go about it. I think having a Word file which is accessible through a screen reader is a good idea. And some of the technology that is out there are some of like things that you can see on the screen. Refreshable Braille displays is a small sort of thing that you see on the screen here. It's a sort of a Braille Ambassador that helps to read the message that is coming through a computer or a iPhone. Tactile image enhancers and CCTV and screen magnifiers. Finally, just to conclude, healthcare inequities exist. That's what my research has shown here, and it was already there before COVID-19, but COVID-19 has further heightened or exacerbated the challenges that these individuals were going through, as well as their healthcare providers. So the challenge for the healthcare providers, because it's really hard for them also to provide best care, though they really want to provide best care to these individuals. To improve care expenses for these older adults, there's a dire need for training of healthcare professionals to accommodate for the communication accessibility needs of these individuals. And I'll say healthcare administrators and policymakers should consider the distinct accessibility and communication needs of this vulnerable population in order to help them age well. As we know that the current telehealth model is not the best way to go about providing best care to these older adults. Yeah, these are some of the take-home messages. I'm not going into details, but pretty much it's all about going ahead and having training on dual sensory loss. If you're working with them, you go and ask them what is their preferred mode of communication, and do not hesitate to reach out to vision and hearing care professionals to understand what could be done best in this particular case, and optimizing the use of residual sensors that they might have, and focusing on some of the live domains that they really value, and providing information in accessible format. Be using extra technology could also be a good idea. So take that extra step to make the world more inclusive. Thank you. Some of references. Thank you.
Thank you very much. My goodness, that was an ambitious 2 studies. I never see qualitative research with 60 people in it, but that was very interesting. I know that we have some vision and hearing experts, or at least I believe so, on the call. It'd be wonderful to ask for some questions or comments or suggestions. You certainly highlighted a lot of concerns and a lot of strategies, and it would be interesting to hear people weigh in on what they think works or doesn't work in their day-to-day practice. So we're open, the floor is open. Please unmute, or if you're uncomfortable unmuting, you can put something in the chat too, if you prefer.
Hey, this is Renu Minhas, and I wanted to share my experience. I mean, I am familiar with the topic and the research presented by Atul. Thank you so much. I just wanted to add my experience. Only 2 days ago, I received a phone call from my eye doctor, which is a follow-up appointment, and the message that was left to me clearly says that if you require any translation, the person accompanying you will not be allowed because of the COVID restrictions. And only translators can be allowed through the phone. So I'm just wondering, if there is a person who is experiencing concurrent hearing and vision loss, how are they going to really operate? Having translation. I mean, luckily I don't have that situation, but I'm just hypothetically bringing this point that this is an eye institute sending this information. So, I mean, I guess they are not familiar that people with the vision problem may also have hearing problem.
Yeah, so is this a question?
No, it's not a question. It is a statement and an observation that it's my personal experience. So I might, when I go for my appointment this Friday, I'm going to tell them that if somebody can't hear, how are you going to really help do the translation through the phone?
Yeah, true, very true. I mean, I think that's what is the key message that we are trying to give through this research. And this year, my third year of my postdoc, I'm just trying to take my research into knowledge translation. So I think even this talk that I'm doing today is one of the knowledge translation. Hopefully, once it is recorded and available online, people might go and see and then see. And also we are coming up with training modules for healthcare professionals. So hopefully that training module could set the little bit of stage or foundation for this work. And because in my data, pharmacists were one of the key population group who completed data. I had never expected pharmacists coming up and sort of completing my survey. And that was the group which predominantly, I think, also experienced a lot of challenges in providing best care to their to their older clients who have hearing and vision loss during this COVID-19. So maybe that's why they shared their stories with us. And it was really interesting to see that people are really trying hard, like pharmacists are really trying hard. And I'm saying like, it's not only about pharmacists, everyone is trying their best. It's just that system and situation is not best to provide the best care. But I think we should take learning from this COVID-19 and sort of move things up in a positive direction.
Thank you.
Thank you. Excellent comment. Yeah. Any other comments or suggestions or thoughts of future research that you'd love to see done? Any of the above? So I just had a question about recruitment. So you said you didn't expect to see so many pharmacists than you did. I guess I missed it if you talked about it. How did you send out the call for potential participants?
Yeah, so basically it was a very sort of streamlined approach. We reached out to all the professional associations, like for doctors, nurses, pharmacists, for all the healthcare providers, be it regulated healthcare providers like doctors, nurses, therapists, and everyone, or unregulated, even PSWs and support providers that are not regulated yet. So we reached out to their association. We requested them to share the survey information with their membership, and through that the recruitment happened. So with that, but pharmacy, I think it was really a surprise to me. But now I think that gave me a clear idea that pharmacists are really worried about, and maybe because they are facing a lot of challenge, because it takes a lot of their time to explain. So if a doctor is prescribing a medicine or whatever, like it's a bit of a work for pharmacists to get the message across to this older adult who is often at the 2 meter distance with them, right, in the pharmacy store. Imagine any pharmacy store, and then how the interaction is happening with that, maintaining that 2 meter distance. So it's a bit of a challenge, and that's what they were struggling a lot, and that's what they highlighted in this data as well, that some of the strategy that they are using and some of the challenges that they are also facing. So yeah, I think that's one major group that I have to focus on.
It's an excellent point. And you also have to have the privacy. So you have to you might be yelling at someone, but you're trying to keep it private. And I hadn't really thought it through until you presented. So Beverly's chat message was, I think this is a great presentation. I hope it will expand people's interest in gaining better knowledge about DSI. So thank you for that comment. Very apropos.
Yeah, thank you, Beverly.
Great.
Yeah, I think here I would, sorry. Please go ahead. No, I was just saying, like, people often think that dual sensory impairment or deaf blindness, like, this is a rare low incidence population. But what I'm trying to say, it's not a low incidence population. It could be any other person who's in our community. Like even in the building where I live in, I have 60% of like residents here are seniors above 65. And I could see that they have difficulty in like they have difficulty in seeing, they have low vision, and also they're using hearing aid. So often they might have also hearing loss. And I see their struggle while sort of going and doing laundry. So because if the laundry is out, like everything is touch, like it has, like there's no more a coin laundry, it's a more sophisticated sort of laundry machine that is out there. They're really struggling to use the card, like the physical card that they might have to use the system, right? So when tapping on a particular spot where you tap, so there are a lot of things that has to happen, I believe, to make things better for people who have concurrent hearing and vision loss.
It's very true. Any other comments or questions or last points? So if not, thank you so much, Atul. This was really very interesting and very important in a neglected population and a growing one, as you stated. So thank you very much. And we're delighted that it's recorded because I think it'll be a good resource for people who are interested in knowing more. So, and thank you to all who came. We really appreciate it. We do have some other talks coming up. The one thing, Susan, Susan, do you have the link to do the assessment? Do you have that link?
Yes.
Okay. Oh, there it is. It's already there. So we have an assessment. I know it seems like a pain to do it, but Atul is just finishing a postdoc. And usually when you start job hunting, they'll ask you for your presentations that you've done and the feedback on that presentation. So it's a big plus for him to be able to have a whole collection of feedback. So if you could take the time, we would really appreciate it. It's in the, it's available in the chat there. All right. Okay, well, thank you, everyone. We really appreciate you coming, and we wish you all the best. We do have some whole series coming up almost every 2 weeks for the rest of the semester. So we hope that some of the topics would be interesting for you. And we haven't finalized the date, but I did want to announce that we are going to have our Abernathy lecture this year, which we are very fortunate. Carl Pilmer, who's a New York Times bestseller, is going to be presenting on the lessons learned from older Americans, sort of the most experienced people. So that book, he was on 60 Minutes with it and things like that. And we're really excited that he's going to be presenting for us. Date to be announced, but probably in March of this year. So please follow us on the website. We also have other information on our website. We have a YouTube channel that you can get linked into. We have a series of lectures on there, as well as we have interviews related to COVID and other things by experts, psychiatric geriatricians, palliative care specialists, just general practitioner oriented. We do also have a monthly, or actually a month-long series of workshops. So the workshops are over 4 weeks, and there's a whole bunch of variety of topics coming. We've got trauma work with older adults coming up. And just this week, we started on age-friendly communities. And we have several more coming on, so please look at that. Oh, and I will add Atul to the list. And there's Nina sent the email out to, if you'd like to be on our email digest, we'll keep you up to date. So thank you, everyone. We really appreciate it, and we wish you a great rest of the day. Bye-bye.
Thank you so much, everyone. Bye-bye.
Thanks. Bye.